Hi, this is Jennifer Merlino, and this is my presentation on scabies, testing and influence on clinical practice for epidemiology for advanced nursing practice, spring of 2018. Scabies is an infestation of the skin by the human itch mite. The microscopic mite burrows into the upper layer of the skin where it lives and lays its eggs. Most common symptoms are intense itching and a pimple-like rash. The mite is usually spread by direct, prolonged skin-to-skin contact with a person who has scabies. It is found worldwide and affects people of all races and social classes. It can spread rapidly under crowded conditions where close body and skin contact is frequent. Examples are nursing homes, extended care facilities, and prisons. Child care facilities are also common sites. The pathophysiology of scabies is that they are 1 to 3 millimeter erythematous papules and vesicles, and they're seen typically in distribution in adults. The vesicles are discrete lesions filled with clear fluid. It typically ranges in 10 to 15 mites live on the host. Little evidence of infection exists during the first month, but after 4 weeks and with subsequent infections, a delayed type of hypersensitivity reaction to the mites, eggs, and feces occurs. The time required to induce immunity in primary infestations probably accounts for the 4-week asymptomatic latent period. With reinfestation, the sensitized individual may develop a rapid reaction. What happens is the skin erupts and is associated with intense itching, which is the hallmark of scabies. The microscopic scabies mite is almost always passed by direct, prolonged skin-to-skin contact with a person who's infected. The infested person can spread scabies even if they have no symptoms. It's primarily mediated by close contact. The elderly are at high risk, particularly when living in long-term care facilities. Animals do not spread human scabies. One thing that I did learn that scabies is considered a sexually acquired disease or infection because it is primarily skin-to-skin contact or fomites, which is bedding or clothing. And the mites can typically be found in warm areas between the fingers and the wrists. Screening recommendations are that a scabies outbreak suggests that transmission has been occurring within the institution for several weeks to months, increasing the likelihood that some infested staff or patients may have had time to spread, including to other facilities in the community. Measures to control scabies depends on the factors such as how many cases are diagnosed or suspected, how long infested persons have been at the institution, and if they've been successfully treated. Because it's so contagious and highly transmissible, crusted scabies requires rapid, aggressive detection, diagnosis, and control treatment measures to prevent and control the spread. The local health department should be notified of any outbreak that may have community implications. Whenever possible, the diagnosis should be confirmed by identifying the mite by dermoscopy. This can be done by carefully removing the mite from the end of its burrow, using the tip of a needle, or by obtaining a skin scraping to examine under a microscope. However, a person can still be infested even if mites, eggs, or fecal matter cannot be found. Fewer than 10 to 15 mites may be present on an infested person who is considered otherwise healthy. Sensitivity of dermoscopy was 0.83, which is 95 confidence interval, and significantly higher than the sensitivity of the adhesive tape test, which we'll talk about in a second. The specificity of dermoscopy was 0.46, 95% confidence interval. By definition, it was 1 for skin scraping and the adhesive tape test. A non-randomized trial using a handheld dermatoscope showed a sensitivity and specificity of 91 and 85% respectively. The specificity dropped to 80% when performed by inexperienced dermoscopists. Dermatoscopy by a trained practitioner has a positive likelihood ratio of 6.5, which is 95% confidence interval, and a negative likelihood ratio of 0.1 for diagnosing scabies. Additional methods of testing that I'd like to discuss is that scabies can also be made, a diagnosis of scabies can also be made clinically in patients with a pruritic rash and characteristic of linear burrows. The diagnosis is confirmed by light microscopic identification of mites, larvae, ova, or feces in skin scrapings. You can also do a biopsy. That's not something that I would typically do. In rare cases, that can be done to rule out other conditions. Clinically, an apparent infection can be detected by amplification of the mite in epidermal scale by polymerase chain reaction assay. Also, you can test for immunoglobulin E titers and eosinophilia, which may be demonstrated in some patients with scabies. The burrow ink test, it can be completed by rubbing a washable felt tip marker across the suspected site and removing the ink with an alcohol wipe. When a burrow is present, the ink penetrates the stratum corneum and delineates the site. This is useful in children and individuals with very few burrows. Skin scraping is definitive testing that relies on the identification of the mites or their eggs, eggshell fragments, or their feces. This is best undertaken by placing a drop of mineral oil directly over the burrow and then superficially scraping it across the skin with a scalpel blade without causing bleeding. Scraping 15 or more burrows often produces 1 or 2 eggs or mites, except in the case of crusted scabies, which many mites will be present. You evaluate it under the microscope and under low and high power with potassium hydroxide. Should not be used since it can dissolve mite pellets. Failure to find mites is common, but it does not rule out the diagnosis of scabies. One test that I've heard that is commonly used is the adhesive tape test, which strips of tape are applied to areas where there are suspected burrows and then rapidly pulled off. Then you apply the tape to a microscope and examine it. It's easy to perform and it has high positive and negative predictive values, making it a good screening test. The sensitivity of skin scraping was judged to be low, but dermatoscopy guided tape testing may be beneficial and should be evaluated. Some problems with testing is that although history and examination of the morphology and the distribution of skin lesions can be clues, definitive diagnosis of scabies infection relies on identification of mites, eggs, feces, and skin scrapings or biopsies. Diagnoses based on symptoms and an empirical trial of scabies treatment is problematic because it can lead to diagnostic error and frustration as well as uncertainty when patients do not improve. Indirect diagnostic methods such as serology have to date been unsuccessful in human infections. Skin scrapings are central to diagnosis and involve the application of 1 or more 2 drops of mineral oil, which is then scraped with a microscope. CLI waiver information is something new to me. I didn't know anything about CLIA waivers, so it was very interesting to learn about this. It turns out that provider-performed microscopy procedures are a select group of moderately complex microscopy tests commonly performed by healthcare providers during patient office visits. Tests included in PPM procedures do not meet the criteria for waiver because they are not simple procedures and they require training and specific skills for test performance. So a CLIA certificate is needed, which allows the physicians, mid-level practitioners, or nurse practitioners, which is more appropriate term, and dentists to perform certain moderate complexity of these microscopic examinations in addition to waived testing during a patient's visit. This testing site or the laboratory site must meet the CLIA quality standards to receive this certificate. Occurrence and implications of false positives and false negatives. Research has found that if treatment was based on clinical diagnosis alone, 27% of their population would have been left untreated and been potential disseminators. 38% of patients would have been unnecessarily treated. This would have decreased to 10 and 12% respectively if treatment decisions were based on dermatoscopy. The limitations that I'd like to talk about, that it is important to remember that a negative result from any of these tests does not necessarily exclude the diagnosis. In that situation, we must rely on our clinical experience and judgment, and this may even include a treatment trial. Dermoscopy is an excellent way to determine a positive diagnosis of scabies and can lead to appropriate treatment, is my final recommendation. It's important to remember that the first time a person gets scabies, they usually have no symptoms for the first 2 to 6 weeks. However, they can still spread it during this time. In addition, treatment is also recommended for household members and sexual contacts, particularly those who have prolonged direct skin-to-skin contact with the infested person. It can be sexually acquired in adults, but is rarely sexually acquired in children. Bedding, clothing, and towels used by infested persons or their household sexual and close contacts anytime during the 3 days before treatment should be decontaminated by washing in hot water and drying in a hot dryer. Or you could seal the items in a plastic bag for at least 72 hours. Use of insecticide sprays and fumigants is not recommended. And here are the references that I used to obtain this information. I hope you enjoyed my presentation, and I look forward to reading all of your presentations as well. This was a great class. Thank you for the last 7 weeks. I learned a lot, and I look forward to learning with you more in the next semester.